Okay, we'll get started now. In way of a confession, since you're already here and the doors are being locked and you can't leave, this is not a classic Grand Rounds. This is going to be an invitation for you to help us teach. The first part of the slides I took is I wanted to show the fun we have in teaching. The talk that I give to the incoming third-year students is Thinking Like a Doctor, and it's based a little bit on Groupman's textbook, but a lot on Sherlock Holmes and how he decided that detectives should be like doctors. So I'm going to remind you that the word doctor comes from the Latin root docere, which means to teach. So the original teacher of PhDs were doctors of philosophy, teachers of philosophy. And we have a wonderful opportunity here to train the future generation of doctors. And I'm going to start with the history and physical, because that's where we really have a lot of need for mentors. And the residents are invited to be mentors as well. As a matter of fact, I'll show you a paper at the end that shows why many interns and residents like teaching students. Then after that, Dr. Ronaldo is going to talk about other teaching opportunities, specifically for the first 2 years. Dr. Scarborough will talk about his integrative medicine course, and then Dr. Morris is going to talk a little bit about the flipped classroom and other novel teaching tools. So what are we doing when we're teaching medical students? We're obviously trying to get them to think critically, not just to memorize a bunch of facts. But what does critical thinking mean? The students will tell you, I'm learning all these facts, but now what? What do I do with them? And what we need to remind them is there's a difference between knowledge, wisdom, and insight. Knowledge is the accumulation of facts and data that you've learned or discovered. So knowing that a path in the desert is 5 miles long, that's knowledge. I know that. I know that path in the desert is 5 miles long. Wisdom is the ability to apply that knowledge in a meaningful way. So how would you apply that knowledge in a meaningful way? You would pack enough water for the trip, right? If you know you got 5 miles in the desert, you'd want to make sure you have enough water. And then the insight allows you to dig deeper. It's a deeper and clearer understanding of the big picture. So what would the insight be? That would be to figure out that you should sell bottled water at the beginning of the trail. So again, our students, their first 2 years are learning lots of data, lots of facts. And so they may have more knowledge than you do. As a matter of fact, I can tell you when I teach Module 1 small group, they know more biochemistry than I do. So they have more knowledge than I might have, but I'm hopeful that at this stage in my career I have a little bit more wisdom and insight. And that's where the teaching comes in, where they've learned the facts, now we teach them how to apply them. Histories and physicals are something that it's becoming a lost art, and we'll talk about that in a little bit. But the question that students will ask you is, when I go to the doctor, they just hand me a piece of paper and I have to check all the boxes. If I had this, if I had that. So students might ask, and you might even ask, why should we take a history instead of just providing the patient with a form that they fill out themselves? Well, one question you should ask yourself is, does that foster the doctor-patient relationship? Well, Abraham Voorhees talks a lot about that. He talks about the ritual and reason behind the bedside evaluation. He talks about, we'll see a little bit later, the eye patient. Patients are being constructed to be an eye patient, where he says if you came from outer space and you looked at a doctor, you would think that their patient was the computer, because they spend a lot more time with the computer. Now they would notice that there's a warm body down the hall that's plugged into all these wires and tubes. And like in the Matrix, they would think that that's the power source for the computer. So they would know a patient's involved somehow, but they would really think that your patient was the computer. And Abraham Voorhees talks about all the bad things that happen when patients get left out of the equation. And you've all had that. I'm certain everybody in this room has walked into a patient's room based upon something you read in the chart and said, oh, so you're ready to go home today. And the patient says, nobody's done anything. They haven't figured out anything. And you go, oh, yeah, we did. We talked to the radiologist. We talked to the pathologist. We reviewed your labs. We reviewed your scans. You're ready to go home. They forgot nobody actually talked to the patient, examined the patient, or took a history. So I would urge you to read that paper about the importance of this bedside evaluation, just not only for ritual's sake, but there's reason behind it. And there's a new book that was just released May 15th, just not even a week ago. Compassionomics by two physicians. And if anybody's interested, let me know. I'll send you TED Talks and the NPR review. They show actual data that if doctors and patients connect, and they connect through the history and physical, initially you're touching the patient, you're talking to the patient, patients will do better with almost any disease you think of. And it makes common sense, because if the patient likes you and they see you as being on their team, they will try harder to do what you want them to do. If they don't like you and they take a pill, they get a side effect, they say, the hell with this, I'm not taking it. So I would urge you all to look at that the connection that you develop with the patient is really, really important, and that connection starts with the history and physical. So why should we take a history instead of just providing patients with the form? Well, again, you've heard me say before, do patients go to medical school to learn how to provide you with a history? And I think the answer is no. We help invoke the narrative. We know what question to ask next. So we need to ask the right questions. So this is an example. This happened to me when I was a very junior faculty at Barnes Hospital in St. Louis. I just finished my HEMONC fellowship. And actually it was a fourth-year student who asked the right question. It wasn't me. I learned from my student. And we had a 22-year-old female referred for the evaluation of iron deficiency anemia. She denied any overt sources of abnormal blood loss. And I asked her specifically, and she denied trauma, injuries, surgeries, childbirths, nosebleeds, vomiting up blood, black tarry stools, maroon stools, no bright red blood for her rectum. She eats plenty of greens and red meats. She also states that her periods are normal. Now what would you ask? That I didn't think of, but the fourth-year medical student did. What is normal? I didn't think of that. I assumed that she went to medical school and that she knew what a normal period was. But that's right, the word normal. So the student says, can you tell me what normal is? Oh yeah, my first few days I wear Depends diapers because I bleed so heavily I don't have time to change pads. And then for the next week I have to change the maxi pads every 2 to 3 hours. And then the next few days, it was very clear this woman had menorrhagia, but didn't know it because she was only she knew. She didn't talk to friends. She didn't have a sister. She just assumed that was normal. So that's an example of where you invoke the narrative. You think of the questions to ask. All right, I'm going to do an experiment. If you have a piece of paper, write it down. If you don't, just think about it. We can hand that out, papers. Okay, what does it mean when a patient says, I have an upset stomach? Think about that. If you have something to write it down. Now I'm going to start with James, and we'll just kind of go down until we get most everything. What does the patient mean? I have an upset stomach, doc. Dyspepsia. Kristen? Nausea. David?
Feeling like throwing up.
Okay. Nausea. Anybody have anything else?
Ask her, you don't know.
Right. Right. Constipation, right? Could be constipated. Could be I'm bloated. Could be diarrhea. Yeah. So keep in mind, patients will tell doctors, I have the weak and dizzies, and doctor writes down weak and dizzy, and they launch their evaluation. So this doctor, James, would have approached this patient different than Christy and different than David would have approached the patient because they came up with different things. And so yeah, nausea, vomiting, diarrhea, constipation, bloating, abdominal pain, and I couldn't get away without thinking of this great commercial. And you all know what's coming.
You can know indigestion, upset stomach, even diarrhea. Dismal. Indigestion, upset stomach.
Okay, so you get the idea that, we don't know what the patient means with lots of conditions that they have. So why should we take a history instead of just getting the information from the chart? That would be the next question. We've already discovered that maybe just giving them a piece of paper isn't good enough, but why not read the chart? Now, back in the old days when I trained, there was one paper chart. And if I was called down to the ER to admit a patient, I never got to see the chart because the nurses were still doing their charting. But nowadays in the electronic record, there's an infinite number of people who could be reading that same information. So why not just get the information from the chart? Well, this is, again, Abraham Voorhees talking about the eye patient. He says the first encounter with the newly admitted patient is electronic. An encounter with the eye patient, which he defines as a virtual construct of the patient in the computer, whom they meet before heading to the emergency department or ward to meet the real patient. In meeting the eye patient first, the medical student no longer needs to ask the time-honored question, what brings you to the hospital today? So you're assuming that the person before you got it right. But can we be certain that the person before us got it right? Keep in mind, history reflects the bias of the historian. When I grew up, the Native Americans were considered savages. They were scalping white people and they were terrorizing the white people. If you see the old cowboy and Indian shows, the Native Americans were the savages, but many of our medical students and younger physicians grew up in a more enlightened time where maybe the Europeans were less than civilized, and maybe they saw the Native American as being peace-loving and one with nature. So keep in mind, the history that you read, it reflects the bias of whoever wrote that history down. So if James doesn't like me because I've been admitted to his service a bunch of times and he thinks I'm a non-compliant substance abuser, he writes it in the chart. He might write that. This is a fifth admission for J. Marion, who is well known that this is a frequent flyer who's got drug-seeking behavior and is a real jerk and non-compliant. Well, I read that. I walk in and let's say you're J. Marion. So what are you doing here again today? I saw they just sent you home a week ago. I bought into his narrative. And so I start off with an attitude, and guess what she's going to do? She's going to get an attitude. And what does that do? It confirms James, because if she's got an attitude, James is right. She's a difficult patient. So keep in mind, that's another reason that starting off with the patient, say, what brings you here? And so I like to encourage the students, and that's one of the great things about the SOPHOMORE H&P. They don't have, sophomores, they can't look up in Epic. They can't see what everybody else saw. They start with their own. Now, this brings me to how doctors think, and many of you know Sir Arthur Conan Doyle was a physician himself, and he based his character Sherlock Holmes on physicians, specifically a very special physician, Dr. Joseph Bell, who was his mentor at Edinburgh Medical School. And what he thought, he watched Edinburgh look for Roth spots and look at, very subtle clues, and as he examined a patient, and very subtle things by taking history. And he thought to himself, if criminal detectives use that same skill set that Dr. Bell used, they would be better detectives. So he came up with his character Sherlock Holmes using the techniques that doctors use, their observational skills, their way of putting together data, their way of using Venn diagrams to figure out who, like Occam's razor, who is most likely to have committed the crime, and created his character Sherlock Holmes, who used every skill set of a doctor to solve criminal behavior. And so Sherlock Holmes, this is an interesting paper you should all read, that his methods of deduction and reasoning were what Sir Conan Doyle got from the medical profession. And so in a study for Scarlet, there's this line that I think is wonderful. It's a capital mistake to theorize before you have all the evidence. It biases your judgment. So again, that ties into what I'm saying is if you open the electronic record first and I read James' comment about what he thinks is going on, I'm going to be biased, and we all know about confirmation bias. I start accepting that which fulfills the bias, and I reject anything that doesn't. But he starts off with it. This is a study of Scarlet where he says it's a capital mistake. He uses that again in A Scandal in Bohemia. He says it's a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit the theories instead of theories to suit the facts. So he's talking about confirmation bias, isn't he? So what were the skill sets that Sherlock Holmes used? One is he gathered the facts, and then he sorted the facts. Okay? Now that would be the H&P. We try to remind our sophomore students, patients didn't go to school to give them a history, so sometimes I might ask a patient, is there any, have you ever had any blood clots or clotting abnormalities? They say no. Then I examine their leg during the physical exam, and I notice their leg's a little bigger, and they go, oh, it's always been like that since I had that blood clot. And then I say, oh, I thought you did. Oh, yeah, no, I forgot to tell you I did. Patients always forget things, but they bring it up later. So we have to have the students invariably, during their first H&P, guess where they're going to put that blood clot history? In the physical exam where they discovered it. They don't sort it and say, actually, this belongs in the history, and go back and amend their history. They'll say, while examining the leg, I saw it was swollen, and the patient said they had a blood clot. Well, I'm not looking at the physical exam for history. I'm looking in the history, so we have to tell the students that they need to not just gather the facts, but sort them. Patients will tell you things when they damn well want to tell you. You can ask about allergies. They'll say they only have allergies, but then later on they mention, oh, I had this terrible reaction to penicillin. They forgot. They didn't think of it as an allergy. Then you have to, Sherlock Holmes said, you have to consider the suspects. And what would that be akin to in medicine? That would be the problem list and differential diagnosis. We think about, okay, so what are the problems and what things could cause those? So I've got chest pain and shortness of breath. That could be an MI, it could be asthma, it could be a lung tumor, it could be a pulmonary embolism. I'm starting to construct a differential, consider the suspects. And then once I've got all the data and I've listed all my problems and come up with the differential, then I want to narrow the list of suspects. And that would be the assessment and plan, where you start saying, okay, I'm thinking it's something cardiopulmonary. I didn't hear wheezing, patient denies wheezing, so I don't think it's asthma. I think it's more pulmonary embolus versus an MI, and now I have to go back and maybe ask some new questions. So what I'm trying to do is to get faculty and residents and fellows to volunteer for a very worthy project. If you bought into anything that I talked about before about the importance of the H&P, then you want young doctors who know how to take histories and physicals. So we're asking for you to sign up to be a preceptor, and we usually do 4 H&Ps over the course of an academic year, so that's 2 a semester, okay? Some people think that's not enough. I'm one of them, but I'll take what I can get. You're generally, 2 students are paired with a faculty preceptor who provides feedback and assists them in the process. And what we don't want is somebody just listening and shaking their head, but they're doing their own computer work or writing prescription. You know, we want you to pay attention and say, now wait a minute, did this belong there? Should have this been in the review of systems, or should have this been in the HPI? Maybe the most important part of the history and physical is the HPI, where you should be able to kind of come up with the diagnosis. I remember Osler basically said if you talk to a patient long enough, they'll always tell you what's wrong with them. So maybe if you talked a little bit longer and focused on your history of present illness, you'd be able to. So It's variable how much time you spend, but I'd say an honest estimate would be 3 to 4 hours per H&P with your 2 students. We are liking at least one, preferably 2, but at least one of the H&Ps should be observed by the preceptor, because you can then give them, you don't have to interrupt while they're talking, but you can give them feedback and say, now when the patient said they were dizzy, you just wrote down dizzy, what might have you asked? Might have you asked if the world was spinning, was it vertigo, or was it just lightheaded, or was it just generalized weakness? So you can give them that feedback. Or as they're asking, they're doing the physical exam, they have the patient lay down, sit up, because a lot of times they'll do the exam in the order they learn to do it. So they listen to the lungs, and they have the patient lay down, they press on the belly, then they have the patient sit up, they listen to the heart. Sometimes you can say all the things that you're going to do with the patient sitting up, you can do those all at once. You don't have to do it in the order that you were taught to do it. And we usually ask that 2 students per preceptor. And if you don't have to remember the names, if you let either me or Christy know if you're interested, we will be sending out emails as well inviting you to do this. Now, for the residents in the room and fellows, what motivates junior doctors to teach medical students? Well, this is a study where basically it was young physicians who were out 1 to 4 years from graduation. So they were classically residents and fellows. And they found that the main motivation to teach was to improve their own knowledge. And you've heard the expression, to teach is to learn. And it is true. When I'm working with medical students, like when I gave you that history of the woman who had the menorrhagia, I learned from a 4th-year medical student that my history wasn't good enough. So you will learn, I promise you, because they know more they have more knowledge than you have. You have more wisdom, but now you put it together and boy, you watch it explode. So they said 80% agreed that they improved their own knowledge, and 72% said, I do it because I enjoy it. I love working with young medical students. It keeps me young. And other less motivating factors were teaching would assist them with their academic career. If you think you're going to pursue an academic career, you're going to put together a teacher's portfolio, and it's nice to be able to say, even as a resident, I, every year, was involved in teaching. Now, I hear from a lot of people the complaints about, medical students, why should we bother? They don't even come to class. They do everything on podcasts. So let's read this. Somebody, James, you want to read it out loud?
The phenomenal strides in every branch of scientific medicine have tended to overload it with detail, to winnow out the wheat from the chaff, and to prepare it in an easily digested shape for the tender stomachs of the 1st and 2nd year student, taxes the resources of the most capable teachers.
Do you think that's a problem we face nowadays? And everybody does, right? So you assume this was just published, right? Do you know who said this and when? Yeah, Osler in 1899. So in 1899, attending physicians were saying, boy, teaching medical students is hard work, and they learn differently, and we have to help them separate. So keep in mind, there's nothing novel. We have a new generation of doctors that students that learn from podcasts. God bless them. I know I prefer having an audience when I'm talking, but it's not about me, it's about them. So again, thank you for listening. Now I want Christy to come up, and she's going to talk about some other teaching opportunities, and then Dr. Scarborough, and then Dr. Morris. Thank you.
Well, as you heard Dr. Marion say, it takes a village to prepare future doctors, and so there are lots of ways to do that. You heard about one with the H&Ps, but how does all this fit in our curriculum? So this is just a basic overview of what we do with our students for the first 2 years. And I've tried to highlight some of the areas where there are opportunities for both faculty, residents, and fellows to get involved in teaching. And what I'm going to focus on more are the small group opportunities that maybe you had not thought of. So here's a list just of the ones that we identified and we're going to try to touch on today, because everybody, like students learn in a different way, faculty like to teach in a different way. Some people feel more comfortable standing behind the lectern, Some people would much rather be in a small group discussion. So there's lots of ways that you can help shape and mold our future doctors. So Module 1, small groups. These are really focused on basic science, and the goal of them is really to help students see how the basic science applies to clinical care. And so for this activity, usually there's one facilitator and about 8 or 9 students in a group. This requires a commitment for 1 semester. So from August to December, once a week for about an hour and a half to 2 hours. I know that's a lot for somebody who's in clinical practice, and so usually if there's an MD who is interested, they'll have a basic science partner. So if you can't be there, you know that the basic science partner can be there. And the facilitators will get a copy of the case that's to be discussed. Students will have to do work prior to coming, so really your job is just to facilitate that discussion. Make sure that they are really thinking about the material and are able to answer questions and again see how it applies to a patient. Flag leader or facilitated learning group leader. These are small groups that are a part of the Foundations of Clinical Medicine course, and these tend to be case-based or topic-based things that are not necessarily the basic science part, but they're issues that students will definitely see once they get on the wards or once they get into the clinics. The great thing about these groups is it's a chance for the 2 group leaders to really get to know a small group of students. It meets maybe 6 to 7 times a year, an hour and a half to maybe 2 hours per meeting. And you truly are the facilitator. We'll send you a leader guide that has a list of potential discussion questions, any background information that you need to know, and you get to just once every 6 weeks or so sit down with the same group of students and really have a conversation, answer their questions, share your knowledge with them. I know as someone who's done flag groups for a long time, I'm kind of there to keep the group on task. Karina's there to answer their questions, and so they listen to her way more than they listen to me. So it's just fun. You really get to see their personalities. You get to see them grow from that very first freshman group where they don't even know what to ask to at the end being very engaged and wanting to know what can I do better to be prepared for third year. So it's a 2-year commitment, 2 group leaders, and like I said, the same group of students for each meeting. So, a lot of fun, and again, a great way to get to know these students. Physical exam instructors. If you can't make or are not sure about making a commitment to small groups and you want to do something that's more of a 1-time or 2-time kind of activity, we desperately need people who want to make sure our students know how to perform physical exams correctly. One of the things I tell the students that I hate to get is a faculty member who calls me and says, "Why did you not teach these students how to perform this exam?" And I'm like, well, we tried, but what we can do is only as good as the instructors that we have. So we really want people who are engaged in this, who are passionate about making sure the physical exam is done appropriately, and you're willing to spend an hour and a half with about 5 or 6 students teaching them one of the physical exams. We provide you the checklist of what we think a student at that level needs to know for this exam, and we want you to demonstrate it for them on a standardized patient, and then watch them do it. We tell the students, this may be the only time you have a faculty preceptor standing there teaching you step by step how to perform the exam. So they will always get to do it on a patient, our standardized patient, and you get to give them feedback, share what you've learned, tricks that you've learned that made it easier for you. So we ask people to commit to doing 2 different physical exam sessions with 2 different groups of students. You can do these back to back, or you can spread them out depending on what your schedule allows. But you can see the list of physical exams that we teach, and we always will send out a call for people who can sign up to teach 1 or 2 of these small group sessions. Again, great way to share your insight and clinical skills with a group of learners. And then this is a really unique opportunity. It's once a year. It's the second half of their freshman year, but this gives you a chance to be creative. If there's an area of medicine or a topic in medicine or something that you are really interested in, but it's not necessarily clinical practice. For example, Dr. Morris was very interested in the documentary Cancer, the Emperor of All Maladies. He really wanted to have a group of students who were interested in that to sit down and discuss it with him. And so he and Terry Davis put this together and facilitated this project for a group of first-year students. You can do something like that, or it could be just volunteering to have a freshman medical student shadow you, to show them what internal medicine is like, or show them what your subspecialty of medicine is like. Just let them spend 8 hours with you. So it can vary depending on what you're interested in, but we're always looking for creative ideas that get students out of the classroom and get them a chance to get involved and engaged with faculty and residents. And then finally, there's always lectures. If you know that, hey, I would just prefer to come and prepare a lecture and come and share with the students for a 50-minute commitment on a topic, absolutely, we would love to have you. So a list of possible topics are there, but if there's something that you are interested in, have done research on, you want to present, you're not sure where it fits in the curriculum, let me know. We'll find a place for you to participate if this is something that you're more comfortable with. And now Dr. Scarborough is going to talk to you about a completely different opportunity that kind of brings all of this together.
All right, so this is the Integrated Processes course, and this has been around since our last major curriculum reform, which is coming up on about 18 years, something like that. So there is time now to do new things. And in the current curriculum, we have this integrated organ system course format that follows. This is so-called Module 2. And it's integrated in the sense that you have anatomy, histophysiology path, and then clinical disease diagnosis and management all together for the blood and lymph or renal or organ system type approach. And it was realized at the time that this was created that you needed an additional something that would help students see the relationship between the organ systems, not just between the basic disciplines within the organ system. And then the other thing was a little something to allow you to emphasize that the basic science concepts do have relevance when you're actually doing clinical medicine. So those were the two ideas here. So we do this in a case study format over 2 successive mornings typically. And on the first day, there's a complex case introduced. And the idea is to introduce it more as it would present itself to a physician seeing the patient for the first time about this problem. So there will be some complaints and there will be some findings and so forth. And we do it so that there are multiple organ systems involved, or at least potentially involved, in what the patient is complaining about. This is done in small groups of about 11 to 12 currently, and the faculty preceptor will help the students work through the case. This is done step by step over about 2 hours, and so let me give you an abbreviated example. This is how a case might start. This is one of them, and it says it's nearly midnight on the second Saturday in July, and Greta Jacobson, a 27-year-old medical student, presents to the emergency department complaining of a severe headache, so there's a problem, generalized aching pain, another problem, and feeling hot for the last 2 days. And then there is a question for the students to try to answer, which is this: what initial questions would you have for Ms. Jacobson? And what we try to do is we try to get the students thinking about how much they can glean from what bits of information that they have. You can tell it's a young woman. it's the summertime, and we have these complaints. And how are you going to begin to explore what's going on so that you can make some useful headway? So you will start out slowly with trying to make as much out of limited data as you can. This is, identifying the suspects and so forth and gathering the facts. So then another question might be, well, what conditions might be causing her headache or her generalized pains? And this is the other part of our emphasis. We want to develop differential diagnosis as a process within the students' minds. And so how many different ways can we get the same symptom? How many different organ system problems, how many different types of pathology can give rise to an upset stomach or a chest pain or a headache or a generalized discomfort? And are there strategies that the students can use to help them think of suspects that may in fact be the guilty party? So, and we typically have these cases develop, and more information is revealed as you go. And in this particular case, we discover in the history that she does have a history of blood clots in her legs, and that she lost pregnancies in her late teens. We also discover that her headache appears to be a meningitis. And another finding is on her forearm there is levator reticularis. Now, this has a differential, of course, and pregnancy loss has a differential, and you're beginning to try to connect the dots by your further investigations and further thinking about what's going on. So more information accumulates and there's more complexity, and a lumbar puncture was done. The results came back, and they're there for the students, and now they need to be interpreted. And they've had a neuro course, and they've had a micro course, and so forth. So they can perhaps interpret some of the findings. Empiric treatment was started, and her fever that she came in with got better, but she had a tachycardia and a leg swelling that prompted an EKG and a lower extremity ultrasound. And then in this particular case, just as these results are becoming available, she suffers a cardiac arrest and can't be resuscitated. So this is a case that I wrote, and it's based upon sad personal experience. So these things do happen, and you certainly don't like it, and the patient doesn't make it, and there you are. So then we have some talk topics for the students to divide up and prepare ahead of the second day, and then they come back on the second day and they go over these things. And what topics were there? Well, meningitis was there. The extrahepatic effects of chronic hep C were one of the topics. Coagulation disorders, pulmonary emboli, cardiac arrest procedures, organ transplantation criteria, and others. And then at the very end of the case, we reveal some late labs and an autopsy report, and it turns out that she had an antiphospholipid syndrome and a lymphoma, making her complicated case. So this is one example. We have many others, and they have different emphases and so forth. There's one case that we do in early November, another in late January, and then we do 3 in a row in mid-April, which is right before they begin to prepare for their step exams in a serious way. So we'll send out notices soliciting your help, and hopefully you can set aside some time if you have enough lead time. We do have booklets that provide instructions for leading the group, how to evaluate the students and score their participation, pictures of the students, outlines of general expectations, and so forth. So you have a lot to work with that tries to make it as simple and easy for you as possible. And we do find that most of the students and most of the group leaders enjoy these quite a bit. You've got interesting clinical material to talk about, you can tell stories, you can be Socratic, and you get to review the foundational physiology and medical science, so it's a refresher perhaps for you. But the emphasis is on the shared experience far more than the grading or the scoring. And we have a lot of opportunities going forward. First of all, we always need the group leaders. We need you to enjoy this type of sort of Socratic teaching in a small group format. We also need your creative juices to think up new cases. And the more specialties and interests that we have inputting, the more broadly we can frame these courses. They need to be freshened up and updated. And we have, of course, a digital learning student group now. And so if you're young enough to have common learning experiences, you'd be ideal for helping us get up to speed with our students. And that includes just the basic structure of the course. And I'm glad to hear from anybody anytime about any of this.
Okay. So I'm separating you from going home, but in the last 15 minutes, I just want to take an opportunity just to introduce the concept of flipped classrooms and some novel education. And it's really demonstrated by this diagram here, where you see the plus sign up in the top hand corner, and that represents the instructor distributing information to the room. In a flipped classroom in a novel education settings, what you see is a change from one person providing the information to multiple people providing information, usually in small group settings. And I became involved in doing novel education in flipped classrooms because the medical curriculum committee asked for volunteers. But I want to step back and ask some things that William Osler has told us. So he says lectures are not enough preparation. Following a patient outmatches many lectures. Learn from each patient, and the study of books alone may spell disaster. And ongoing education in medicine is important. So you take this concept of going beyond the book, going beyond a lecture to help in your educational activities. So when we look at this, the first thing I want you to do is to pair share. So there's somebody sitting next to you, and if you're not sitting next to somebody, I want you to interact with somebody next to you. And I want you to think about this question here. What have you learned so far in this presentation? And share that with the person next to you, and vice versa. So let's spend the next 30 seconds doing that. Go ahead. Okay, so we'll bring it back to the front. And so now, who learned something that you had not appreciated? Okay? So something was learned by the person next to you that you had not appreciated in the lecture. Okay? And that person told you about that. That's peer learning. That's one of the bases of a flipped classroom, where the instructor is moved away from the instruction and your peers provide much of the instruction for you, or there's self-directed learning that occurs. This is an example of a flipped style classroom. So what you see in Bloom's taxonomy, if you look at education, is that in the beginning of education, you look at things and you recall facts, or you explain ideas. When you begin to interact with other learners, then you're allowed the ability to draw connections among ideas. You get to justify a stand or a decision. So you explain what you learned and why you learned that in this exercise we just did. And then you can begin the process of creation. So one of the things that we also see in educational activities is something based on Gagne's 9 events of education. And it's pronounced Gagne like Kanye West. Okay, so that's how you can remember it. So what I did when we started this exercise, we gained your attention. And then that led to informative learners of what we're going to do. And then we stimulated recall of prior knowledge. We prevent our stimulus. We provide guidance. Then we elicit a performance. We provide feedback on that performance. Then we begin the process of assessing the performance and enhance retention and transfer. So in the course of an educational activity, these are the things that you want to see in successful educational activities. And it's difficult to do that when you have somebody who is a sage on the stage and moving to the guide on the side. Okay? So if you're providing a lecture and you're just providing the information, you're not getting the feedback back in a lecture in order to find out, are the learners acquiring the information? So this is a way to both provide education and get immediate feedback. So if we look at this is really learn by doing. And for some people in the room, this is a very familiar symbol. Remember that the 4-H clubs were invented by the U.S. Department of Agriculture as a way of demonstrating new techniques and providing it to youth. At one point, it was the largest youth organization in the country, and their slogan is learn by doing. And those of you who were 4-Hers will remember that basically all the educational activities in 4-H clubs were based not on a reading exercise, but by doing something and learning it by doing. So if we look at flipped classrooms, it's really an inversion of the traditional delivery of material from a teacher to a learner. Everybody here has participated in a flipped classroom. If you took a humanities class, such as Shakespeare or any of the great British writers, in which you read something and then came to the class and discussed what you gained from the book, that's a type of flipped classroom. It's been used in the humanities area for a long period of time. And really the learner is the center of the educational delivery. So it moves, again, the sage from the stage to the guide on the side. And a typical outline for somebody who is doing a flipped classroom is to do some type of pre-course work, a video or a reading material, to have in-class activities, and then a summary at the end. Some have been a little bit more strict in the idea of a flipped classroom and talking about flipped learning, and say that it has to have a flexible environment, there must be a learning culture, intentional content, and a professional educator. I don't know that that's necessary to occur, but one of the things that you see in a flipped classroom is you move away from one-sided delivery of education. So, as we've seen before, flag groups are a perfect example of this flipped classroom style learning. So you see things like patient interviews and substance abuse. We see development of history. That's actually one of my favorite activities in the flag groups, is to develop a history where a narrative is given and the students have to pull that out and use a whiteboard to generate those ideas. We recently did direct-to-consumer advertising, looking at that, geriatrics, ward team ethics, and then another patient interview was chronic disease management with the patient on dialysis, in which the patient provides the information to the student. It's not driven by somebody who is a professional educator. The other example that Dr. Renato gave was for immersion groups. So if you look at immersion groups, these are a great idea if you have an idea or an area that you're interested in, that you can take that, build it into a curriculum. So the example that she gave was my example of the cancer. And what happened here is I saw the film, and if you haven't seen the film, The Emperor of All Maladies, which is a Ken Burns film by Barack Goodman, it is a history of cancer. But more importantly, it provides a human face to cancer and shows the struggles of cancer. So as approximately 4 years ago, I came and said I'd like to do this as part of the curriculum, gathered the material up, recruited Dr. Davis to come and assist me, and we meet with freshman medical students. They watch the film or they can read the book, and then we come in and discuss it. And this is an example of narrative medicine. So it's an idea of integrating empathy, reflection, profession, and trust and creativity, because we ask them to write an essay on their feelings and what they get from an exercise such as this, to integrate that into the curriculum. So we're moving up again on Bloom's taxonomy. The other areas that people have looked at are hospice and empathy, difficulty in communication, transgender health, and some hot topics. Dr. Scarborough introduced you to the Socratic method and problem solving, which is part of the immersion groups. We use that also in the Module 1, where you follow a molecule or a concept in the biochemistry or anatomy, and we'll work through that. I use this in what's called problem-focused workshops. So in this case, it's similar to the integrative in that you present a case. You have these core concepts that need to be addressed. So I use such things as chronic diarrhea, which tends to have a problem for students to memorize. You use this as problem solving. You have active discussion and interaction with the learner, and so there's a feedback instantaneously in these settings. And then you have independent learning, for example, in the integrative process, where the learner then goes from the classroom to look up a topic and then come back and report on that. So a lot of flipped classroom techniques use recorder-reporter style formats where the person gathers the information and then reports it back to the group. The overall goal in a lot of these processes are review of material to also focus in on difficult concepts. And remember that a lot of adult learning principle is built on the premise that repetition is important and then the application of that principle. We've also used role-playing. So role-playing is integrated in Module 1 for us, where we looked at 2 lectures. The introduction to the abdominal exam, which I was assigned, and then imaging of the abdominal cavity was originally something that Dr. Maureen Hillman, who's left the institution, we were looking at delivery of this material and decided that maybe we could combine this together. So we use a role play format of the physician, the patient, and off to the side is the radiologist. So we use this role play almost as if it's in real time. And so we're able to go through appendicitis, cholecystitis, peptic ulcer disease, and diverticulitis, where you present a patient, they tell you a assault history, you then examine the patient in an interaction where both the clinician and the patient are showing the students what actually goes on. And then we say we'd like some imaging studies. We then defer to the radiologist, who then chimes in and says, well, if you have this type of problem, this is what we look for in the x-ray. And then we proceed on to explain the process. It seems to be a very popular lecture among the students, and it seems to be a delivery that's novel. This can be akin to this picture here. For the Disney files in the room, you'll recognize this. Dr. Arnold immediately recognized this. This is a picture of Epcot. So what this allowed us to do is do what Disney did in the late 70s. They took 2 parks, realized that they were going to be a mediocre park, put it together, and you created Epcot, which became a great park when it was created. So you have Future World to the left, and you have the World's Fair style park here to the right. Okay? So you have to think out the box and see if you can be creative with other people. Another project that I've looked at is something called 2510 crowdsourcing. So this is a method to randomize students into groups. What it allows you to do is take concepts from a lecture. So I use this for the irritable bowel syndrome lecture. And what we do is we have the students on a small note card write a concept down. And then you have 5 people in the room rate how good of a concept that was. Okay? And you have this randomization that occurs. The top score is, if you say it's 1 to 5, 1 being worst, 5 being best, is 25. And what you do is if you have 120 students, there's going to be people who got high score in the concept rating. Those high ratings become your basis for your lecture. You can then make small groups out of those 10 concepts that then allows the students to then write your curriculum for you as you're doing the lecture. And so the advantage of this process is it allows a minority voice to be heard. So the person who's not vocal but has a great idea can write it down. It's peer-reviewed and said that's an excellent concept, and then it allows that to be brought forth and to be executed for. So it's a very popular format to do a structural lecture or decide things. And here's an example of earlier this year where the students have been randomized. They've now split up into groups, and they're developing the concepts and curriculum for this lecture on irritable bowel syndrome. And they're given 10 minutes to do this. And this is what you see. So they came up with the core concept of one person for clinical symptoms. Here are the clinical symptoms for IBS. But even more erudite in 10 minutes is this here. Here's the treatment. And notice in 10 minutes they've separated into primary treatments, secondary treatments, and then based on the symptomology. This is all done in about 10 minutes. So you can see that learners are very adept at adapting and creating if given the opportunity. I'm going to go to something called concept mapping and algorithms. So this is a strategy for organizing material. So it can be instructor-driven or lecture-driven, and it often suggests relationships between concepts and helps to organize and structure knowledge. And if we look at that, if you were looking at elevated liver chemistries, you can just list them here. But another way of looking at them is to build a framework. And I don't have this on the whiteboard. This is my notes that I use for a whiteboard. Here's a framework for AST and ALT, and over the course of several minutes, you can develop an algorithm for the workup of AST and ALT. When you look at this from the standpoint of memorization and learning and adaptability and integration, this concept map is much easier to remember and much easier to take and utilize clinically than is a list of liver chemistries. I'm going to skip over this for the time. We talked about physical exam skills. There's something called Make and Kindling, and I can talk about that to anybody who wants to stay behind. There are online modules that you can use. Flag groups use these in one of them, and then the ALCLS, that is an online module, is a way to use digital media to come up with a method of teaching. That's what Dr. Scarborough talked about. I want to end with popcorn. So what I'd like to do is everybody take a sheet of paper. Pass it around. What I want you to do on this piece of paper as it comes around is I want you to write a test question from this lecture. It could be from my part, Dr. Scarborough's, Dr. Renato's, or from Dr. Marion's. So I want you to write a test question. Everybody got it? If you need an extra few more seconds, raise your hand. Everybody got it? Okay. I want everybody to stand up. Okay. Everybody face the center of the room. Okay. Take your sheet of paper, scrunch it up. You got it? Scrunched up? I want you to toss it to the center of the room. Now I want you to, we'll pick up the paper. Here you go. Okay. Everybody got their paper? Open it up. You now have a test question review for your lecture that's peer created, okay? So this is a way that you can get students to be involved in writing test questions. You can collect these up and make these into review questions, or you can take these home and answer your questions. So you've created two questions. One is the question that you wrote, but also somebody from your peer, okay? And I want to credit Dr. Turpin, who taught us this in one of our educational activities. So, okay, thank you.
If you're interested in any of the things we talked about, there are lots of people within the department who have participated and will be happy to share their names if you want to get advice from somebody else. So thank y'all for listening.